and Dr. Khalid Rasali, and my supervisor, Dr. Manfred Rizzo, and Dr. Angelo. Okay. I'm going to talk about LDL cholesterol as the only targeted therapy. So why LDL cholesterol? Lowering of LDL cholesterol with a standard statin regimen reduces the risk of occlusive vascular events in a wide range of individuals. Further reduction in LDL cholesterol safely produce definite further reductions in the incidence of heart attack, of revascularization, and of ischemic stroke with each 1 millimole per liter reduction that reduces the annual rate of these major vascular events just over 50. Standard statin regimens like the intermediate or low intensity statins like simvastatin here typically reduces LDL cholesterol concentration by about a third, but regimens involving higher intensity and higher doses, newer and more potent statins like atorvastatin and Rozova can halve LDL cholesterol. Many trials have proved the effect of lowering statin LDL, cholesterol only, like PROVE-IT, TNT, Ideal, Search, and many others like 4S's and Jupiter, Ascot. Here we can see the events per annum percentage. The one group compared with the control, there is a huge difference in percentage and with the benefit. According to the guidelines of 2016 European guidelines, LDL is recommended to be used as the primary lipid analysis for screening, risk estimation, diagnosis, and management. Even here in effects on major vascular events per 1 millimole per liter reduction in LDL cholesterol baseline, even in persons that has previous vascular diseases like coronary heart disease, non-coronary diabetes, male or female, age, and hypertension, and so on, it improves to be so effective in reduction of the events per annum. So there is a marked cardiovascular disease reduction. Particular consideration was given to results from systematic reviews confirming the dose-dependent reduction in cardiovascular disease with LDL cholesterol only lowering. The greater the LDL reduction, the greater cardiovascular risk reduction. The benefit of LDL reduction are not specific for one statin therapy. No level of LDL cholesterol below which benefit ceases or harm occurs has been defined. There is also evidence suggesting that lowering LDL beyond goals that were set in the previous ESC 2012 is associated with fewer cardiovascular events. Therefore, it seems appropriate to reduce LDL cholesterol as low as possible, at least in patients at very high risk cardiovascular risk. LDL is the primary target for therapy. Here we can see, since all trials use LDL cholesterol, we still recommend this as the primary treatment target. However, non-HDL cholesterol should be used as the secondary target when the LDL goals is reached. Goals for non-HDL is calculated, and that should be more by 30 milligram of the optimal LDL goal. So non-HDL cholesterol is secondary targets have also been defined by interference. For non-HDL and for ApoB, they receive a moderate grading as they are not extensively studied in randomized clinical trials, as just stated. Okay, adjusting lipid lowering therapy in accordance with these secondary targets may be considered after having achieved the goals of lowering LDL cholesterol at very high cardiovascular risk. According to the guidelines, this is the secondary non-HDL cholesterol secondary target, and for very high and high and moderate risk. There is a reduction in mortality with the reduction of LDL cholesterol in the large cholesterol treatment trialists. CTT analysis data were included. This patient's participant, 170,000 participants, a 10% proportional reduction in all-cause mortality and a 20% proportional reduction in CAD death per only 1 millimole, 40 milligram per deciliter LDL cholesterol reduction. The risk of major coronary events was reduced by 23%, the stroke by 70% by the same 1 millimole reduction. The benefits were similar in all subgroups examined. The benefits were significant within the first year, but were greater in the subsequent years. The lower is the better with the LDL. Current available evidence from meta-analyses suggests that the clinical benefit is largely independent for the type of statin, but depends on the extent of LDL lowering. Therefore, the type of statin used should reflect the LDL cholesterol goal in a given patient. According to the guidelines of 2016 ASC, LDL cholesterol is recommended as the primary target for treatment class 1A, while non-HDL cholesterol should be considered as a secondary treatment target class 2A/B. But at the end, the take-home message that you have to be wise. Clinicians should use clinical judgment when considering further treatment intensification in patients at high or very high total cardiovascular risk. Thank you for your listening.